Invitation to speak. So just briefly about, I'm the Vice President for Research at IBIS Reproductive Health. We're a small nonprofit research organization. We do clinical and social science research all related to reproductive health in the US, Latin America, and Sub-Saharan Africa. IBIS was started by Charlotte Ellertson, who went through the program here. Some of you may know. I'm going to be talking some about work I've been doing on improving access to early medical abortion through the use of telemedicine. This was actually from last March. Some of you may have seen this graphic from Mother Jones, the anti-choice March Madness, where it seemed like each state legislature was sort of competing with each other to see who could come up with the most restrictive abortion law. In this, North Dakota was named the anti-choice champion. They came up with a law that would have banned abortion at about 6 weeks, time an embryonic heartbeat can be seen on ultrasound. Most of these laws then turned into court fights, and many of them have been blocked in the courts, either temporarily if not permanently enjoined. Texas might gotten the prize for the most restrictive law that actually went into effect. Some of you may know about the very restrictive law that was passed in Texas that requires physicians at abortion clinics to have admitting privileges in hospitals within 30 miles of the clinic. It restricts medical abortion, restricts abortion after 22 weeks, and in September of this year will require clinics to essentially meet the criteria of ambulatory surgery centers. So all of this to say that sort of the fight for abortion rights is certainly taking place at the states. Kind of a snapshot of abortion access in the US, for those of you for whom this isn't the focus of your work. In 2011, 89% of counties did not have an abortion provider located in that county, and 38% of women of reproductive age lived in those counties. I mentioned the restrictive law in Texas that just went into effect, and that kind of builds on another law that actually was passed in 2011 that requires women to make an extra visit to the clinic at least 24 hours before the abortion to obtain an ultrasound and have the ultrasound clearly explained to her before she can have the abortion. Between 2011 and 2013, we're involved in monitoring the impact of these abortion laws there. 50% of the clinics in Texas have closed. And once the final ASC, ambulatory surgery center requirement goes into effect, if that isn't stopped by the courts, essentially 85% of the clinics will have closed. These laws are sometimes referred to as targeted restrictions of abortion providers, or TRAP laws, and they're threatening to close sometimes the sole remaining clinic in some states, for example in Mississippi, which will really severely limit abortion access in some of these states. So all this is really very depressing for those of us who work in the area of reproductive rights. So today I'm going to focus on something that's a little more positive about an intervention that's actually showing some promise at improving access to early abortion. So some of you may not be so familiar with medical abortion. So the medical abortion regimen that's approved in the US involves two medications: mifepristone, also known as RU-486, followed by misoprostol, which is a prostaglandin type of medication. And so when we talk about early medical abortion, we're talking about medical abortion generally up to 9 weeks. Just recently there's more and more data that it can also be effectively used up to 10 weeks, but for the purposes of this talk, we're talking generally about 9 weeks of pregnancy, where women take these medications. Generally she takes the first pill in a clinic, and then she takes the second pills at home 24 to 48 hours later, and essentially she has an experience similar to a miscarriage and expels the pregnancy at home. And this regimen of mifepristone followed by misoprostol is very effective to cause a complete abortion. It's about 95 to 99% effective. So that means that somewhere between 1 to 5% of women need to have a surgical procedure or an aspiration or vacuum procedure to complete the abortion. But for the vast majority of women, it's effective. There's a great deal of data now, including some published by your very own Cleveland here, documenting the safety and effectiveness of early medical abortion in the United States, as well as high levels of acceptability. So women who choose this option are very satisfied with the method. When mifepristone was approved in 2000, there was kind of a feeling among some in the abortion rights area that this was kind of going to be a disruptive technology that was going to really change the way abortion access looked in the U.S., and that there would be many more providers offering access to abortion, and that it would really revolutionize how women could access abortion care. And that really has not happened. Part of that has to do with how the FDA requires that the medication be distributed. It has to be through a physician's office. And uptake has really been slow to provide the method at physicians' offices other than places that were already providing abortion care. There was an analysis done by the Guttmacher Institute in 2005 that showed that a very small proportion, less than 0.5%, of providers that were only providing mifepristone medical abortion were located more than 50 miles from a surgical provider. So at least up until that time, there hadn't been a lot of evidence that medical abortion was really doing much to improve access to abortion. Part of that is related to this. So medical abortion is a very simple, non-surgical procedure. Provision of the method basically involves determining whether a woman is eligible for the method, so whether she is in the gestational age window, so if she's past 9 weeks, or as I said, now there's evidence up to 10 weeks, she's not eligible for the method, or whether she has one of a very short list of medical contraindications, then the method isn't appropriate for her. Most of the evaluation with a woman is counseling to make sure, first of all, that she's sure about the abortion decision, but also that she's sure she understands what medical abortion will involve and whether that method is best for her as opposed to a surgical abortion. So it's a very simple process and there is evidence that it can be safely provided by non-physicians, by nurse practitioners, by nurse midwives, by physician's assistants. In fact, in most of the U.S., these non-physician providers are not allowed to provide the method. So 39 states, these states in red, including Alaska and Hawaii, which didn't make it onto the map, have laws that say only a physician can provide an abortion. In many cases, these laws kind of harken back to the days of unsafe abortion and were meant to ensure that women were only not obtaining an abortion from a quack and only obtaining it from a physician. But in many instances, these laws have been extended to explicitly or kind of thought to extend to medical abortion as well. And so only in about 11 states are there specific laws that do allow these non-physician providers to provide the method. In a few other states, despite having these laws, there are either opinions written by attorneys general who have said that, in fact, nurse practitioners can provide the method, but those are really just a handful of additional ones. So we're going to be talking some about Iowa, which is one of these states where a physician has to provide an abortion, and that has been extended to medical abortion as well, so that a physician has to actually hand over the medication for medical abortion, and that's really limited access in these kinds of states. So as you know from the title of my talk, I'm also going to be talking some about telemedicine. Telemedicine is the delivery of healthcare services at a distance through information and communication technology. There are many, many applications, as I'm sure you know, about how telemedicine is being used in the U.S. Sometimes it allows a specialist physician to provide consultation to primary care physician that might be located in another physical location, sometimes to a non-physician provider. It's being used a lot in this way, for example, in the military, in settings where there may be a medic, but not a physician, certainly with specialty training. In some cases, it's used to actually provide direct physician-to-patient outpatient care of some sort, most often mental health services, but there are many, many applications. In general, the evaluations that have been done of many telemedicine services have shown clinical outcomes that are comparable to in-person treatment. And certainly there's a big push toward telemedicine in many states and also at the federal level as well. So I'm going to be talking some about this telemedicine model that was initiated in Iowa. So in 2008, when Planned Parenthood of the Heartland, the main Planned Parenthood affiliate there, started this model, they provided about 3/4 of the abortions in the state. And I'm just going to, 1 second, let's see. So they provided about 3/4 of the abortions in the state. They had 17 clinic sites, but at only 2 of those did they have a physician who was providing abortion at those clinics. And then those physicians traveled to 4 other sites to sometimes offer, in a couple of them, surgical abortion, but more commonly to hand out the medical abortion pill. So I just want to show you this quick animation to explain the telemedicine model that they developed. So as I mentioned, the way that it used to work before they started telemedicine was that about every 2 weeks or so, the doctor would get in her car and she would then drive about 200 miles to one of these outlying clinics where she would see maybe 4 or 5 women who were interested in having a medical abortion and essentially hand out the mifepristone tablets and go through the instructions with them when they get back in her car and drive back to Des Moines. So the way the telemedicine model works now, it starts in a centralized pharmacy in Des Moines where they pre-package individual doses of the mifepristone and misoprostol. They then distribute these to the outlying clinics. A woman comes into one of these outlying clinics where she's evaluated by someone who does an ultrasound and takes a detailed medical history. So there's not a physician in this outlying clinic. That staff person in the outlying clinic then uploads the ultrasound image to a secure server as well as the medical history. And then the physician in Des Moines can review that medical history, look at the ultrasound image, determine whether the woman is appropriate medically for medical abortion, then has a video chat with the patient, again kind of goes over, determines that the woman is eligible and appropriate for medical abortion. And if the physician determines she is, then she types the code into her computer that unlocks a preloaded drawer in the remote clinic where the individual doses of the mifepristone and misoprostol have been loaded into that drawer. Then the woman takes the 2 pills out, she takes the mifepristone, she gets her final instructions from the health worker in the remote clinic, and she leaves. And then she comes back, generally a week or 2 weeks later for a follow-up visit at this remote clinic where she just gets evaluated by the clinic staff in the remote clinic. And if the doctor needs to be consulted, then the doctor is available either by telephone or for the video chat. So this just gives you an idea of the geographic distribution of the sites before telemedicine. So the circles are the triangles are the sites where surgical abortion and medical abortion were being offered by a physician, either because the physicians were located there or they would travel to those sites. The 2 circle sites are the sites where the physician would sometimes travel there every couple of weeks to offer medical abortion. These stars then are the new sites offering telemedicine, that just medical abortion via telemedicine, that were initiated the service after the telemedicine model was launched. I don't know if some of you might have seen the recent paper from the Guttmacher Institute by Rachel Jones that was recently published, which the 2011 abortion provider census, which showed that overall there was a 4% decrease in the number of abortion providers in the U.S. between 2008 and 2011. But if you looked at the table that showed all the breakdown by the states, in fact, Iowa was a bit of an anomaly where there was a 64% increase in the number of sites offering abortion care, increased from 11 to 18, and that was essentially all due to these new telemedicine sites that began. So I'm going to be talking some about the evaluation that we did looking at this model. We performed a review of the adverse events to try to assess the safety of telemedicine. We did a prospective cohort study comparing the telemedicine model to standard in-person delivery of medical abortion, looking at the effectiveness of the regimen and acceptability. We did in-depth interviews with clients and staff, looking at acceptability and feasibility of the model, and then we reviewed the service delivery statistics of Planned Parenthood to look at sort of how they changed after the service was initiated. So in terms of the adverse event analysis, any provider, anyone who enters into a prescriber agreement with the manufacturer, Danco, is required by the FDA to report certain adverse events to the manufacturer and eventually to the FDA. These include things like ongoing pregnancy, hospital admission, treatment in the emergency department, treatment with intravenous antibiotics, blood transfusions, unrecognized ectopic pregnancies, allergic reaction, death, or other major complications that essentially require hospitalizations. So we reviewed all of these adverse events that were reported between the period shortly after the model was initiated, so on July 1st, 2008 through the end of October of 2009. You can see during this period there were a little over 3,500 medical abortions provided. About 2,400 of those were in-person visits because there was a physician at the clinic where the woman came, and close to 1,200 were telemedicine visits. During this period there were 46 adverse events, so a total of 1.3% of the medical abortions were associated with an adverse event. And then we compared the incidence of these adverse events between telemedicine and the in-person groups. And here you can see the prevalence was essentially not identical overall between the two groups. You can also see the prevalence of ongoing pregnancy, about 1% in both of the groups. Blood transfusion was 0.3%. In the telemedicine and in the in-person group, it was 0.1%. You can see how the 95% confidence intervals for each of these proportions overlaps. And for any adverse event in a multivariable analysis, the odds of a woman having an adverse event who went through telemedicine was essentially 1 compared to those who had an in-person visit. So for the cohort study, we performed this between December 2008 and September 2009. We recruited adult women who were seeking medical abortion at one of 5 clinics. One of the clinics provided only in-person provision of medical abortion. 3 of the clinics only provided telemedicine, and 1 clinic provided both models, depending on whether there was a physician there or not. All women went through the standard regimen of medical abortion that I mentioned. So they were up to 9 weeks of pregnancy. They took mifepristone 200 milligrams orally, followed 24 to 48 hours later by 800 micrograms of misoprostol buccally. Talk more about that if you're interested. We collected clinical information on the first day when they came into the clinic, and then also when they came back for a follow-up visit. They were to essentially confirm whether the abortion was complete. And then women were asked to complete a self-administered questionnaire at the time of that follow-up visit. Women who didn't return for the follow-up visit were called both by the clinic to try to get them to come back for their follow-up visit, but also by the interviewers as part of the study to complete the questionnaire over the phone. This shows just sort of the breakdown of the study flow for the cohort study. During this period, there were a little over 1,000 women who underwent medical abortion, 500 more or less in either both the telemedicine group and standard in-person provision. A little bit more than half of the women were actually recruited into the study, and the reason why those were not recruited were often because they weren't. This was like in a busy context of a busy clinic, and women often weren't given information about the study. In the end, so we had 281 women in the telemedicine group that had the day 1 data, 297 with day 1 data from the standard in-person arm. There was some loss to follow-up of women who didn't come back to the clinic and we were not able to reach by telephone. Overall, it was about 22% of women who were lost to follow-up, which is fairly comparable to other studies of medical abortion. So we had 223 women with follow-up data in the telemedicine group and 226 women in the standard in-person group. And just to say again, women were not randomized to their treatment, so they called Planned Parenthood and were connected with a call center that gave them information about both the closest clinic and the soonest appointment they could get. And then they were told, if that happened to be a telemedicine site, that it was a telemedicine site and what that involved. And so women made a choice about essentially what treatment that they wanted to receive. This shows some of the demographics between the two groups. Generally, they were quite similar in terms of age, race, and ethnicity. You can see that the telemedicine group had a significantly higher proportion that had education beyond high school, 54% versus 42%. This shows some of the reproductive health characteristics of the two groups. Again, a higher proportion in the standard or in-person group had a prior abortion. The gestational age at the time of the abortion was similar in both groups, average of about 46 days, and very few women had a significant medical history of any type. This shows the result of the effectiveness of the medical abortion regimen, and there's certainly no biological reason why we would think that telemedicine would be less effective, but it is possible that maybe women wouldn't understand the instructions as well and maybe not take the medication as they were supposed to. But in fact, we found that there was no difference. In fact, the effectiveness was a little bit higher in the telemedicine group, but not statistically so. 99% versus 97% in a multivariable analysis that also adjusted for demographic covariates as well as adjusting for clustering within the clinic sites. You can see the odds ratio of having an effective abortion at telemedicine compared to an in-person visit. This was the confidence interval overlaps 1. We had a number of questions on the questionnaire looking at acceptability. This was a question related to overall how satisfied are you with the abortion service you received here. Again, this was being completed at the time of a follow-up visit, so at least 2 weeks after having gone through the initial visit that involved telemedicine. Telemedicine patients, 94% of them said that they overall were very satisfied compared to 88% of those who had an in-person visit. In the simple bivariate analysis, this was significant, but in adjusting for other covariates in a multivariable model that also adjusted for clustering, the confidence interval crossed 1. This is another measure of acceptability, asking if they had a friend who was in a similar situation and was seeking an abortion, would they recommend the service that they had received at the clinic where they had received it? Would they recommend that she have medical abortion at that clinic? You can see 90% of the telemedicine clients said that they would recommend to a friend compared to 83% in the standard group. And this multivariable model, adjusting again for covariates and clustering, this was significant. So women who went through telemedicine had a significantly higher odds of saying they would recommend the service to a friend. We also had some open questions in the questionnaire about what they liked best about the service and what they liked least. In general, these responses were pretty similar in both the telemedicine group and the in-person group. People liked the staff, the information that they received, they didn't feel judged. In terms of what they liked least, about 60% overall either left that question blank or said nothing that they liked least. But the most common answer to this open-ended question was they didn't like how long they had to wait in the clinic, and a significantly higher proportion of women who had an in-person visit complained about the wait time in the clinic compared to those who went through a telemedicine visit. And that's often because in these telemedicine sites, they were smaller clinics. There were many fewer abortion patients on the schedule at one day, so they didn't have to wait as long. We also asked them how many days, what was the interval between when they first called Planned Parenthood and when they actually got their appointment. And you can see that that interval was significantly shorter for the women who had a telemedicine visit, 7.6 days compared to 10 days. For the women who did have a telemedicine visit, we asked some specific questions about the telemedicine service, and pretty much all of the telemedicine patients said that it was easy to see the doctor, easy to hear the doctor. Most said they felt comfortable asking questions. A quarter of women, however, did say that they would have preferred to be in the same room with the physician if that had been possible. They then had the opportunity to kind of write in more about that answer, and in general, those responses indicated that, yeah, in an ideal world, they would have liked to have been in the same room with the doctor, but kind of weighing that against the fact that they wanted to either have their abortion closer to home or sooner, it was kind of worth that trade-off to have the telemedicine visit. You can see some of these responses that people wrote in. One woman said, "I'm always generally more comfortable dealing with serious issues in person." Another one said, "Yeah, it was rather irritating, but probably faster and more convenient. I'm a face-to-face person." And this is the results of a multivariable analysis that looked at the covariates that were associated with that 25% reporting that they would prefer to be in person. You can see that younger women, age 18 to 25, compared to older women, had a significantly higher odds of saying they prefer to be in person with the physician, as did women with lower levels of education and nulliparous women, so women who didn't have children compared to Paris. So for the women who went through telemedicine were also asked if they had any suggestions for improving the service, and this one about getting rid of that drawer came up again and again. And I don't think I'm really going to have time, but we've since kind of worked with some both legal experts and technology experts to simplify the model for use in other settings, and we followed this advice and got rid of the drawer. Because as you can imagine, like all kind of newfangled technology, sometimes the drawer didn't work, didn't open. Then, the clinic staff would be there like banging on the drawer, and they just had to open it and do it so. But it was also interesting that often women didn't know, they didn't understand why they even had to talk to the doctor. They felt like the whole, talking to the nurse practitioner or the clinic staff person in the remote clinic was sufficient. They got all their questions answered, and they didn't understand why they even had to have this video chat. Like all things, how many of you looked at other evaluations with telemedicine, but this issue, but often, I'm a doctor, we're not very comfortable being on camera and don't know exactly what we look like, and so sometimes, the doctor didn't necessarily always look very professional, and so we heard this from some of the participants, and sometimes she was not in a professional-looking setting. Another thing that quite a few participants mentioned was that they would have liked to have had the opportunity to be alone with the doctor during the video chat, because the way the model was set up, the staff person in the remote clinic was always in the room with the patient. And some of this has since been introduced, kind of implemented in the model there. One question we had when we were doing this evaluation was whether women might feel pressured to have a medical abortion if that was the only service available at a clinic that was either closer to her home or was at a place where she could get in sooner. And I think these responses from the survey kind of give us some idea that, in fact, that wasn't the case. We had a question about, so when you asking, when you were deciding about having a medical abortion or a surgical abortion, how did you feel? And did you strongly want the pill? Were you leaning toward the pill? Were you leaning toward having a surgical abortion? And in fact, we saw no difference in the two groups between the telemedicine and in-person groups. So about 70% said that basically from the outset they strongly wanted to have the medical abortion. You can see that a significantly higher proportion of the telemedicine clients said that having an abortion close to home was very important to them, and both groups overwhelmingly said that having an abortion early was very important to them. I'm going to talk some about some of the in-depth interviews that we did with women and with staff. We did 25 in-depth interviews with women, 20 who went through telemedicine, and 5 who had in-person services. I'm just going to talk about the telemedicine ones today. And then we also did 15 in-depth interviews with some of the providers at these sites that were offering telemedicine, both physicians, nurses, center managers, and the counselors and educators. This is a quote from a center manager at a telemedicine clinic. She said, "My very, very favorite part about this is that we had a patient present in the office one day, and she had made the decision that she wanted an abortion, and we were just able to do it that day. I mean, she really needed it, and she needed it that day, and I just thought it was just amazing that we could do that for her in that day, so she could move on in her life." So that was kind of one of those, wow, this is great type of moments. And I would say that that kind of echoed a lot of the sentiments of the clinic staff, that they felt a lot of kind of personal and professional pride about being a part of this new service that they felt really improved access to early abortion in more remote parts of the state. From the interviews with women, we heard from women that they mainly chose where, the clinic site where they were going to get the abortion based on, first of all, distance. This woman said, "I didn't want to drive to Iowa City and have it done and then have to drive back. I didn't want an 1.5 hour ride home in bad weather. I just figured that this would be the easiest way." But also for timing, both to have the abortion as soon as possible. So this woman said, "I really wanted to take care of the procedure as soon as I could," but also to ensure that they could have a medical abortion. So as I mentioned, at the time of the study, medical abortion was only available up to 9 weeks of pregnancy. So for some of these women, their only option to be able to get medical abortion is if they went to a telemedicine site. If they had tried to wait to get into one of the sites where the physician was based, they would have been past the 9-week limit. So this woman said, "I wanted to make sure I got here as quick as I could before you can't do the pill anymore." And the fact that telemedicine was being provided at the clinics really didn't figure in their decision. This woman said, I don't think it influenced me at all. I just thought it was a neat way to use the new technology, and it was a convenient way to take advantage of it." We asked women about how they felt when they were told about how their visit was going to be with telemedicine before they actually got there. In general, they thought it sounded like it would be more convenient, and they trusted the clinic, Planned Parenthood, that they would provide them with quality care. This woman said, "My first thought was like, well, I mean, it's an easier way. It's easier for the doctor. She doesn't have to be at every place, and I mean, it's more convenient for her, and she can just be at one place for the day, and she can just do it do a video chat instead of driving so many miles out of the way just for a few seconds." Another woman said, "Different. I thought it was different, but I had enough trust that you guys, they would provide good enough care that wouldn't be a factor." One woman of the 20 who went through telemedicine said that she did feel a bit nervous about telemedicine, but kind of in the end, it was more important for her to go to the clinic that was closest to her home. She said it was a little nerve-wracking after they said there wasn't an actual doctor present, but the teleconference thing was fine. I wanted to get in here because I wanted the closest. In terms of women's experiences with telemedicine, most of the women thought it was kind of weird or different, or kind of the words that they often used at first, but that ultimately, after they went through it, it worked out just fine. It didn't really seem any different. Some women compared it to using Skype that they use otherwise, for other reasons. For some women, interestingly, the anonymity of the video chat was actually a positive thing. They felt like it kind of introduced a little bit of a barrier between them and the doctor, which they actually liked, which I think is interesting. You can see this first one said it was different. It's a bit more comfortable than face-to-face, because I mean, obviously, it's a little embarrassing, when you're going to do something like that. Over the computer, it's a little bit easier, rather than face-to-face, probably. Another woman said, "I would prefer it in person. Just makes me feel a little bit better that they're sitting right in front of you. Eye contact I'm a big eye contact person. I get eye contact over the conference deal, but it's not the same as having them right there in front of you." A few women in these interviews talked about concerns about privacy, including concerns about internet connection security. And I should say the way this model was actually set up, it didn't actually go through the public internet. They set up kind of dedicated data connections between their sites to ensure that there were no issues with data security. In fact, other models that we're now working with technology experts, I mean, it is possible to use the public internet using encrypted video conference software. So this woman said, "Internet is crazy or whatever." I don't know if it's internet, but certain people, I don't know if they get into hacking and stuff, but you can get technical with all of that. But I'd just rather have it be face to face. Some women talked about it. They were concerned that maybe there was someone else in the room with the doctor that she couldn't see, that maybe this was somehow being broadcast. But these were really minority views. I would say most women overall felt that the video chat felt private and secure. In terms of how the providers felt, this is a quote from one of the doctors who said, essentially she could be now in 3 places at once. The access to women is just amazing. I can sit here at my desk and take care of 25, 30 women across the state, and they can be a couple of hundred miles away. I used to drive to the centers, and I could only visit so many centers a day or a week, so this is just amazing. Some of the other staff talked about how it has ended up reducing the number of visits required for women at these outlying clinics. She said if we had a full schedule, we would do pre-ops on Tuesday, so they would have women kind of come in for their first evaluation to go through all the screening and have the ultrasound and laboratory testing done ahead of time. And then those patients would have to come back on Wednesday because the doctor would only be there for an hour, so the patients would have to make 2 trips. Now they can see all the women in one day. Services were also now available to women on more days, and there was a lot more flexibility. This person at his clinic said the big difference really is that you'll be able to offer it more frequently because I can call the doctor and say, you know what, I really have this patient, she can only do it on Friday, will that work? And then as is a very real concern in Iowa with the inclement weather, overall there were just fewer cancellations. So now I want to talk a little bit about what actually happened in terms of access to abortion after telemedicine was introduced. So for this analysis, we worked with de-identified billing data from Planned Parenthood, and we had access to all of the data, the abortion encounters over essentially a 4-year period, comprising close to 18,000 abortions. Of course, the data in this kind of data set are limited. We had information such as age, patient age, race and ethnicity, education level, residential zip code, whether the patient received financial assistance at the clinic to pay for her abortion. In terms of gestational age, it was only recorded in relation to procedure type. So we knew if it was an early medical abortion, which would have been up to 9 weeks, if it was a surgical abortion between 6 and 13 weeks, or if it was a surgical abortion beyond 13 weeks or done in the 2nd trimester, but we don't have any sort of more granular data on gestational age. And then we compared several outcomes that I'm going to be showing, looking at the 2-year period before telemedicine was introduced compared to the 2-year period after. So as you can see here, not surprisingly, since all of these new clinics were only providing medical abortion increased after telemedicine introduction from 46% for the 2 years prior to telemedicine introduction compared to 54% for the 2 years after. Overall, after adjusting for other covariates in a multivariable model, women had a 1.5 increased odds of obtaining medical abortion in the period after telemedicine was introduced. The vast majority of the abortions were done in the 1st trimester, about 96%. But after the introduction of telemedicine, there was a small but significant decrease in the proportion of abortions that were done after 13 weeks. And this is important because we know that abortions performed in the 2nd trimester, although very safe, do have a higher risk of complications compared to 1st trimester abortions. And they also are more costly to the patient. So this small but significant reduction is actually important. You can see controlling for other covariates, presenting after telemedicine did have significantly higher odds of having an abortion performed at 13 weeks or less early in pregnancy. The distance that women traveled to get to the clinic decreased slightly, which in some ways we were initially a bit surprised by this, but so this is one-way travel. On average, decreased from 33 miles to 30.7 miles. also in a linear regression model after controlling for other covariates. On average, there was a 3-mile decrease for women. I think part of that has to do with the fact that while some women did choose a telemedicine site because it was closer to their home, others chose it because they could get in sooner. And so in some cases, women actually would travel farther to get to a telemedicine site if it meant that they could get in sooner or get a medical abortion. These next findings, I believe, indicate that abortion access for women living in more remote parts of the state did increase after telemedicine was introduced. So this shows the proportion of clients living more than 25 miles from a clinic that provided only surgical abortion. And you can see that if we looked at all of the abortions together, that proportion who lived more than 25 miles away from one of these sites increased from 40 to 44%. Looking just at the medical abortion patients, that proportion increased from 43% to 48%. If we look at the proportion of clients living more than 50 miles from one of those clinics that only provide surgical abortion, for all the abortions together, it increased from 24% to 26%, and among medical abortion clients, it increased from 27% to 31%. So these are the results. So we created some smoothed maps to look at how the abortion services changed during the 2 years after introducing telemedicine according to women's residence. So for each zip code, we calculated the difference in the number of abortions that were provided essentially after telemedicine was introduced compared to the number that were provided before telemedicine was introduced, in order to identify spatial clusters of increased or decreased abortion cases after the introduction of telemedicine. And so all of the blue represents sort of an increase in the number of, and this is just for medical abortion, an increase in the number of medical abortions according to the woman's residential zip code. And the darker the blue, the larger the magnitude of the increase. And then similarly, red increases indicates a reduction in the number of cases. And you can see here how the number of medical abortions kind of increased for women residing throughout the state, but particularly in the western part of the state, in eastern Nebraska. Most of these increases occurred near the telemedicine sites, which are shown by those yellow triangles. And you can see also that most of that increase occurred among women living more than 50 miles from these 4 clinics that provided the surgical abortion. So the 50-mile radius is the dashed line. This shows some of the findings related to surgical abortion. And you can see that surgical abortion decreased actually throughout the state, most markedly in the central part of the state and around Des Moines. So given all these findings, I don't know if you want to take a guess as to what happened in Iowa overall in terms of the abortion rate. Any takers? Any ideas? This is what happened to the abortion rate in Iowa over this time period. So you can see that there already, and if we had looked farther out, there was kind of a slow decline in the abortion rate overall in the state that we've also been seeing nationally and also in specific states where we have these data, and that decrease in the abortion rate actually became, if anything, perhaps more steep after telemedicine was introduced. I should say, you probably were guessing, there was something else going on, and there was. There was a big project called the Iowa Initiative to Reduce Unintended Pregnancies that was funded by a large donor to push the use of long-acting reversible contraception in publicly funded clinics. That particularly had, and that started in about 2008, and particularly had a lot of uptake in some of the larger urban areas, which probably also accounts for some of the reduction in surgical abortion, particularly that we saw around Des Moines. So some of the limitations of this evaluation, as I mentioned, it's not a randomized trial, and women chose the treatment that they received. I mentioned that in the cohort study, there was a significant loss to follow-up, 22%, but as I also said, that's similar to other studies on medical abortion. Certainly, other factors may have contributed to the changes that we saw in in the 2 years after telemedicine was introduced. However, I can say, the fact that the proportion of abortions that were medical abortion going from essentially 45% to 55% is really quite striking. During the same period nationally, according to the Guttmacher data, the proportion of all abortions that were medical increased from 14% to 17%. So this is quite a big difference compared to the other national data. Certainly the results of our evaluation are specific to this model that was set up in Iowa and can't really extrapolate it to other telemedicine models. In terms of, I think that there are certain strengths of the evaluation, the fact that the adverse event analysis and the service delivery analyses use the entire universe of abortion encounters for the analyses. So just in terms of conclusion, the clinical outcomes, effectiveness, and safety with telemedicine provision seem really quite comparable to those with a standard in-person visit. The acceptability was high, satisfaction levels were high among women who chose this model. It seems like the time to get an appointment was reduced for women who went through telemedicine. There were fewer complaints about waiting time. After telemedicine was introduced, there were certainly more clinic sites providing abortion in the state. Medical abortion increased. Second trimester abortion decreased. There was a small decrease in distance traveled by clients, and I mentioned perhaps why that might not have been more. And it does appear that more women in remote parts of the state accessed abortion, and particularly accessed medical abortion. And all of this in the context of a continued statewide decline, downward trend in the overall abortion rate. So that all sounds fairly good. So then what happened? Well, states started passing all sorts of laws to ban telemedicine provision of medical abortion. So I believe so far now there are 14 states that have passed laws that specifically require a physician to be in the physical presence of a woman when handing out the medical abortion drug. So all these red states. The blue ones are states where they also passed these laws. These two states, so in North Dakota they passed the law and it's now been permanently enjoined. In both Iowa, so Iowa's an interesting example. Actually, the way they did it was through the Board of Medicine. So a complaint was brought by Operation Rescue, which is an anti-choice group, to the Board of Medicine actually initially in 2010. And the Board of Medicine investigated and determined that the model in Iowa was fully compliant with all the state regulations, and the case was closed. The governor then got all new members onto the Board of Medicine, including a Catholic priest and several other people who have expressed anti-choice views. And then last year they issued new regulations that would have banned telemedicine and required the physician to be in the same room with the client. They rushed this through very quickly. They had a public hearing that I also presented these data at. Representatives of the Iowa Medical Society testified saying they were very concerned that this was potentially a slippery slope that could lead to limiting telemedicine for other medical services, which is a real concern in Iowa because this is one of the states where telemedicine, it's a very rural state, and telemedicine is being pushed. Despite that, 2 days later after this hearing and receiving like over 1,000 pages of comments that there's no way they could have reviewed, they approved this regulation that would put this ban into place. Planned Parenthood sued. A judge has temporarily enjoined the regulation, and there's going to be a case later this spring. Anyway, I'd just like to acknowledge the donor who supported this work, staff of Planned Parenthood Heartland, and they were really the ones who came up with the clinical model. We simply evaluated it, but also thank them for their participation in the evaluation. Study participants and my other investigators, Kate Grinley and Kelly Blanchard at IBUS, Todd Buacher, who's with Planned Parenthood, Kathleen Lane, who's with the Abortion Access Project, Joseph Potter with the University of Texas, and Carl Schmertman, who's at the University of South Florida. Thank you. I'd be happy to take any questions.